that we all participate in, and now all those results are on my hospitals and fed back to all of you, and so Lindsay is the driver of that, who's got the funding together and makes it keep on going. He's also spent quite a length of time at Geneva with WHO, where he, again, was very much involved in rolling out international programs on antimicrobial use and resistance in people around the world. And while there, he obviously made a lot of contacts, because the program we've got in Australia, the 5 Moments, is based very much on what is now being promoted by WHO and Dept, particularly from Geneva, which is a worldwide program. So Australia and Switzerland with Didier are at the forefront of this, and Lindsay is a major person involved. Lindsay's has numerous publications, but he also is the editor of a major, if you like, textbook of infectious diseases on antimicrobials, which is called Infectious, which is probably the gold standard for this information around the world. So I think we're now ready to go. So without any further ado, I'll welcome Lindsay up to give his talk, which is something I might say I have a lot of interest in, which is superbugs and supermarkets. Thank you.
Thanks very much, Peter, for that very kind introduction. I think we're okay with that. Yeah. I've never been accused of needing a microphone before, so don't think I'm going to need one now. Thanks for that. You've taken up half my time, though, Peter. And thanks to Hannah and the organising committee for inviting me to speak today. So what I thought we would cover today is firstly the current situation regarding antimicrobial resistance and new drug development, problem new bacteria and mobile resistance, 5 practical steps towards controlling the situation without new drugs. Some of you will have heard this before. The concept of One Health, of which Peter's obviously been a key leader in Australia, and why food is the new frontier, and then finally what we can do about it here in Australia. So if you were on Mars and you were looking down on the Earth, whether you are from my favourite Martian a long time ago or a Martian like this, you would see the following, and that is that prior to 1940 there were no antibiotics, that these wonder drugs were invented in penicillin in 1940, and that within the space of 70 years, that's 2 to 3 human generations, antibiotics have now been misused such that we have rapidly emerging multi-drug resistance, whether in gram-positives, gram-negatives, TB, or in other organisms like Clostridium difficile. So my mum was born in 1928, about 12 to 13 years before penicillin was invented. She lived her whole lifetime as a child without any antibiotics, but by the time she died, we were already having in my hospital 4 to 5 patients a year dying with bugs that couldn't be treated anymore. So in her entire lifetime, this change had occurred. So it's little wonder that Dame Sally Davies from the UK has likened the emergence of antibiotic resistance to that of terrorism and its effect on the world. So as an infectious disease physician, I think one of the things we do for the public is confuse them with terms like gram-positive and gram-negative when they don't know what a gram stain is. So perhaps we could talk about bugs in terms of 4 categories. Those that are skin-based, like Staph aureus, whether it's methicillin-resistant or not, and Acinetobacter. Usually you can intervene with topical things such as alcohol-based hand rub. Nose and throat infections, respiratory pathogens that is, such as strep pneumo and Haemophilus, largely responsive to vaccinations, actually. Sexually transmitted disease, which is hard to control, requires condoms or a change in personal behaviour, and no one uses any intellect below the navel. So this is a problem, and it's probably why we now have multi-resistant gonorrhoea that is completely untreatable with any currently available antibiotic just discovered in the Philippines. And then finally, a topic mainly for today of gastrointestinal and urinary infections, where the gut flora and the pathogens associated with the gut, such as Enterobacteriaceae and VRE, commonly cause urinary tract sepsis, obviously, because the anatomy is pretty close to each other. So recently this summary came out from WHO summarising the recent status of antibiotic resistance, where they for the first time actually surveyed all of the available data from labs reporting resistance across the world. And as you'll see from the right-hand column there, the 5 of the 6 WHO regions are now reporting resistance rates. Oops, excuse me. 5 of the 6 regions are now reporting resistance rates that to E. coli, Klebsiella. The majority of the sites are recording high levels of resistance. So this is not just a simple problem in one or two locations. And in fact, for those of you who followed this story about NDM or New Delhi metallo-beta-lactamase, this is this new strain of E. coli and other gram-negatives that carry multi-resistant genes that seems to have emerged particularly in India. And of course, with migration now, it's popping up all through the UK. And that you can see that the number of isolates has gone up dramatically, and then the number of antibiotics to which it's susceptible is minimal, so that now we're left with really colistin and tigecycline if you have one of these infections. And that if this is a map of New Delhi from the recent publications showing that the green sites are where there are drinking water taps where this bug was grown from the drinking water, and the red sites where it was grown just in puddles on the surface water of the soil around New Delhi. And it's estimated that about 1/3 of the New Delhi population now has this multi-resistant strain of E. coli colonising their gut, a bug that will be hard to remove. And obviously when they get their intra-abdominal sepsis or their urinary tract sepsis, it is more likely now to be with this multi-resistant organism acquired through the food, through contaminated water, than it is their previously non-resistant strain of E. coli. So, of course, for some of us, from Australia's point of view, these bugs can be brought back in terms of travellers returning where they've had medical care overseas or been travelling overseas, and this is a paper by Kira Chua in our group where we summarised a group of recently returned travellers who'd spent time in hospitals overseas. And if you look at this map, you can see that the different areas to where Australians go for travel, so that the Southeast Asian region and India and China and so forth are very, very common sites for travel destination, and obviously therefore it's a high likelihood either they've picked up bugs in the water or the food, or if they've been unlucky enough to get sick and require hospitalisation, that they're very likely to have acquired a pathogen, particularly in the hotspots of Europe, such as Greece and Spain. Particularly Greece is pretty much the septic tank of Europe now in terms of its hospital strains. And with their economy declining, these sort of things are only getting worse. So in the past we would have just said, well, what about new antibiotics? I'm afraid there's not much to tell you about this. This is the number of drug companies in 1980 manufacturing and discovering new drugs. This is 1998, this is 2010, and currently there are 3. So there has been a massive decline in the number of companies producing and investigating new drugs. The answer is not in new drugs. And in fact, this graphic from WHO shows potentially the discovery void since just before 1990, that there have essentially been no new classes of drugs identified in the last 15 to 18 years. So one of the reasons for this, perhaps among many, some of course are the finances of, it's less valuable to discover a new antibiotic than it is to discover a new anti-lipid agent. I'm taking Crestor. And I'll take that once, every night for the rest of my life with no one telling me to stop taking it because resistance will develop. Well, that anti-lipid agent is more valuable to the company than developing an antibiotic that I might only take for 3 or 4 days. So, nevertheless, there are some interesting other reasons why new discovery has declined, and that is in the past, traditionally, antibiotics were collected and isolated from natural sources and primarily from soil specimens, and that synthetic medicinal chemistry was used to then purify and improve those products. Whereas in about the 1990s, the natural products were de-emphasised, and instead there was a reliance on bacterial genomics. And so this led to a whole lot of new drugs being discovered, but it was very, very critical to each company that they had an appropriate library of new genomes if they were going to discover new drugs. And so, although they could use high throughput screening to identify these, basically the quality of their compound libraries dictated whether there are any new compounds being identified. And pretty much all the companies had the same libraries. So in fact, although they discovered a number of novel targets by this approach, none of these products really proceeded beyond phase 2 clinical studies as they would have previously in terms of the natural product research. So it's subsequently led to this paper and others, this one by Helen Boucher in Boston, summarising the decline in new drug discovery, IDSA coming out with programs like this, Bad Bugs, New Drugs, Need for New Drugs, and trying to look at new models of funding for new drug development. And this is just a graph from Helen's paper showing the fact that there's hardly any new drugs. So if you were Tom Hanks and you're sitting in Apollo 13, you would be saying, well, Houston, we have a problem. So in the past, we've traditionally thought about controlling antibiotic resistance in hospitals by limiting the emergence of new multi-drug resistant pathogens, and then as a secondary feature, the infection control issues about limiting transmission of existing multi-drug resistant pathogens. And my view now is actually that this needs to be reversed. The bushfire is running. Yes, we need new fire trucks. Yes, we need new helicopters, but they're 10 to 15 years away. That's how long it'll take for the new drugs to be developed. And what we need to do is cut a fire break to try and protect, to limit the spread of the problems we have already, and to protect us from any future worsening of this situation. And that's called infection control. And for some of you, you've heard this, my 5 points before, but I'll beat you up with it again. And that is that there are five, in my view, 5 practical steps to controlling antimicrobial resistance, or AMR, without new drugs. And we can look back to the past to actually give us some clues to this. So if you say, well, what is the basics of controlling disease? The main benefit brought to humankind was not antibiotics. It was actually clean water, sanitation and housing. All engineering solutions, not involving doctors. It was only afterwards that we decided that reducing cross-transmission in hospitals was important, and this was led by Florence Nightingale, who obviously recognised the importance of spatial separation of infected patients, and Ignace Semmelweis, who identified the importance of hand hygiene in preventing cross-transmission. And then finally, 5th out of this came along, it was antibiotics that came along. So the pyramid would look something like this, where the antibiotics are right on the very tip of the pyramid, but on a basis of clean water, sanitation and improved housing. So my 5 practical steps are, naturally, as Peter's introduced, as Director of Hand Hygiene Australia, I think hand hygiene is pretty important. It helps reduce cross-transmission, whereas tightening antibiotic control helps reduce new emergence. And because of the WHO program, some time back Australia joined this program, with various states having tried to initiate their own hand hygiene modules, including mine in Victoria. But eventually we joined the 5 Moments program for hand hygiene. And with this has really been a dramatic change in the number of, so this graph just shows the number of hospitals across Australia. So in this last audit period in June this year, there are now 782 hospitals reporting to Hand Hygiene Australia 3 times a year, with the lighter coloured bars being private hospitals. The split for this now is about 95% of all acute public hospital beds are reporting to Hand Hygiene Australia, and a bit over 50% of the private hospital beds. We summarised the outcomes of the first 2 years a few years ago now. We're now up to 5 years, and a new paper will be coming out shortly. But with this, we showed a significant decline in the rate of MRSA in the period after the introduction of the program. But of course, subsequently, Peter and Brett Mitchell have recently published this paper in Clinical Infectious Disease, showing that across Australia there's been a steady decline in the rate of Staph aureus bacteremia, SABs, both MRSA and methicillin-susceptible Staph aureus, with the key declines being in the last few years. And although hand hygiene cannot claim all the glory for this, it's been part of a package of different interventions. I think its awareness-raising potential has been pretty critical. So currently, hand hygiene, the Hand Hygiene Australia program is now by far the largest and most successful national hand hygiene initiative anywhere in the world. As I've said already, 782 sites, mostly public, but about half of that number in private. We now have more than 6 million moments in the Hand Hygiene Australia database with electronic data submission. The June results just announced yesterday are actually across the country 81%, having started at about 19% 5 years ago. Medical staff remain an ongoing challenge, but at the latest audit we're just under 70%. So when people say doctors are slow, that's true. They're about 5 years behind the nurses, but at least they are improving. And we've seen major impacts in reducing national rates of healthcare associated Staph aureus bacteremia, whether it's raw numbers, such as 2,600 Staph bacteremias a few years ago to only 1,700 2 years ago, or the data that Peter and Brett have shown about declining rates. So this is a photo from recently where Didier Pitte from WHO visited us, and Chris Bagley, now our Chief Medical Officer, and Madeline Cruikshanks and Phil Russo, who's been incredibly influential in getting things going, Paul Johnson and many others, where Australia was nominated as one of 3 sites of Centre of Excellence by the WHO for hand hygiene. But what's more important than any of that is this document from my daughter's Year 9 reading class, where in Victoria English comprehension they actually had to read this document about the importance of hand hygiene and how to alcohol rub your hands as part of their English comprehension. Because once we get the average voter understanding the importance of hand hygiene, that's when the politicians will listen, as they are starting to do, and that starts with the young. What about improved hospital cleaning is the second of my suggestions. Well, here's a graph from my hospital where, despite all our hand hygiene and falling rates of staff, we've actually seen an increase in rates of VRE, and this is because VRE, rather than being related to hand hygiene, is more related to cleaning. And we know that in the past 40 years, at least in Victoria, there's been a decline in the priority of good cleaning. There are no national cleaning standards for hospitals in Australia. Cleaners are one of the lowest paid and least educated workforce. At least in my hospital a few years ago, 10% of all our cleaners were illiterate in any language. They were good people, it's just you couldn't give them written information. They were very proud of their work, but there was a different approach needed to educate them. They had very non-standardised cleaning practices. In fact, the record was 9 cleaning products in one of the cleaners' cupboards, and he often used to put a squirt of our alcohol rub into the bucket as well because he heard that was good. That there are plenty of poor motivation, but environmental contamination with all these different bugs that are listed there is critical. And we've done various surveys showing that things like the weigh chair were universally contaminated with VRE if you had a couple of VRE colonised patients in the ward. So we decided to treat the whole of the Austin as a cesspit and just assume that it was all completely contaminated, and that if we knew that it was VRE contaminated, we would routinely clean with bleach. Well, why didn't we just start to get rid of all the other products and only use a bleach-based cleaning product? And so that's what we did. You can see all the years of medical education, specialist education, going overseas to Harvard and whatever, it all came down to the length of this hose and whether it fell below the edge of the bucket and stopped causing splashing of the bleach and was mixing with cold water and so forth. But with this, we got rid of all the other products and moved to one single step. We introduced cleaning supervisors so that they could actually check that the cleaning was done properly, this new miraculous approach. And we abandoned CDC dress codes in terms of long sleeve gowns and gloves, and instead opted for an apron such as this and relying on alcohol-based hand rub instead of the wearing of gloves. And in fact, the cost savings from getting rid of the gowns and gloves was so massive that we paid for all the salaries of the 7 new cleaning supervisors in that money, not because the gowns and gloves cost a lot of money, but the yellow bag that they went into because they were deemed as infectious waste is about 15 times more expensive to dispose of than a routine bag. And so the savings were enormous. And with that, we saw a just over 1/3 reduction, 37.4% reduction in the rate of new VRE colonisation, a stabilisation of the overall burden of colonisation, which in our liver transplant unit is running at about 1/3 of all the transplant recipients, and a reduced inpatient acquisition rate, but more importantly, a 70% reduction in VRE bacteremia related to this. We summarised this in this paper in the Journal of Hospital Infection, and we consider this universal approach to cleaning where you assume the hospital's dirty. In fact, my professor of medicine in our department said, you know, Lindsay, the hospital smells like hospitals used to 15 or 20 years ago, you know, with bleach. And I said, yeah, remember before we had superbugs? And oh yeah, okay. And so, you know, I think this is a neat approach, and it also means that when you have a norovirus outbreak or a C. diff outbreak, you've already got the same product, so you're just reinforcing the same standard. National standards for invasive device insertion and maintenance. Well, obviously we put in a lot of invasive devices such as these, and peripheral IV lines are pretty important, as summarised here by Rhonda Stewart and Paul Johnson, showing that the rates of staph bacteremia go up astronomically after 72 hours, after an IV's been in place for 72 hours. And so we decided to review our peripheral IV cannula policy, and in fact I was interested to find out we actually had 6 policies, the shortest of which was 27 pages at my hospital. and that we had multiple different dressing trays, we often using non-sterile gloves. Rarely anyone used no-touch technique, even though one claims that you should do this. And that we found that aside from hand hygiene, peripheral IVs were the #1 cause of Austin-associated, that is my hospital-associated Staph aureus bacteremias, and we were running about 2 a month. And yet each one of those cost the hospital about $25,000 more per case to manage. So we decided to develop our own IV insertion pack and a new policy which only contained that information and that material that we actually required for IV insertion. And we decided that there should be a sticker in the notes whenever an IV was put in, and there should be a sticker on the IV, and if there's no sticker on the IV, the nurse just pulls it out. It means it's been put in incorrectly. You can see the training video on this YouTube website. And so we developed a new hospital standard or nurse standard where it was actually mandatory for nursing staff to follow this, otherwise they would get cited. And this was that all IVs that are inserted by the ambulance were to be removed in ED, or if they weren't, immediately on admission to the ward. That all IVs must have an insertion sticker. No sticker means removal by the nurse without asking the doctor. It doesn't matter how hard the needle was to get in, it's removed. All IVs are to be removed at 72 hours, no permissions required except in paediatrics, where there's obviously specific issues. And then we audited against this maintenance standard. And just a copy of those standards. So here's our rate of staph peripheral IV line, staph bacteremias per month for the 18 months prior to the intervention. You can see they're running at roughly 2 to 3 a month. Here's the intervention period, and this is the response subsequent to the intervention. So if you calculate it according to rate, as in per 10,000 occupied bed days, there's a highly statistically significant reduction from 0.47 per 10,000 to 0.09, p-value of 0.003, and this paper should be coming out in the next month or so. Of course, there are plenty of other, as I've mentioned, sterile procedures that we should look at, particularly urinary catheters. You know, when you consider that about 1/3 of all women who get a urinary catheter associated with surgery get a urinary tract infection afterwards, it's unbelievable, and most of this is related to poor insertion technique, and the fact that Australia does not have a standard approach to inserting, whether it's peripheral IV lines or urinary catheters, is really ridiculous when we think of all the other things we spend money on, and this is seemingly such a simple thing to look at. Improved hospital design. Well, really this is pretty simple and brief, because whether you've got, all comes down to the patient to toilet ratio, and whether your bum's like this or preferably like this, it's 1 bum per toilet. And so this is a simple new mantra for all architects of hospitals, and that is 1 bum per toilet. And the importance of not sharing toilets, particularly for gram-negative or gut bacteria, is critical if you're going to try and stop transmission. And then finally, of course, is tightening antibiotic prescribing control. And this is a whole topic in itself, but we all know that there's an overload of antibiotics being used. That, back in 2000, prior to Peter going to, proposed that these drugs should not be used in food production because of the risk of development of resistance and cross-transmission. So this brings us to the term of One Health, and really the title of this talk, and why food is the new frontier. So why is that the case? Well, obviously gut flora are a common cause, as I've mentioned already, of intra-abdominal infections, including the gallbladder, urinary infections, particularly in women, obviously because the urethra and the rectum are close by and the urethra is short, and obviously in older people in terms of aspiration, pneumonia. And gut flora is altered by the ingestion of food, both the bacteria, in obvious case picking up salmonella or something that's going to make you sick, but what about picking up E. coli that don't actually make you sick but then just sit in your gut until they cause problems later? And of course there's also not just the bacteria, but actually the genes that they carry with them, and we'll come back to this. And those genes, though, can either be located on the chromosome, where they don't tend to move much unless they're on transposons, or they can be highly mobile, such as in plasmids. And then, of course, there's the antibiotic residue that may be present in that food as part of its production. Or finally, of course, the gut flora can be altered by taking of antibiotics. And when you think about it, recently there's been some studies looking at, how much do we know about faeces? And only about 8% of the genetic material in our faeces is actually coming from bugs that we know what the species are. The other 92% is coming from undiscovered organisms so far. So there's a lot to learn about poo. Now, I'm going to introduce this term about ESBLs, or extended spectrum beta-lactamases. Why? Well, because these ESBLs are a critical resistance component which denotes resistance to all the penicillins and, in some cases, cephalosporins, and if they're broad enough, in fact, even the carbapenems, such as meropenem. And similar to other resistance genes, they can be either inherent in the organism, such as the so-called escapum organisms, those species listed there, or they can be acquired through plasmids. They're now very common. They're mostly on mobile genetic elements, such as plasmids, and they can switch susceptible gram-negative bacteria, or GNBs, into ESBL-containing multi-resistant superbugs. And so potentially they can affect all the gut gram-negatives. They're often co-located with other resistance genes, so though they denote resistance to beta-lactams, they often are co-located with resistance to aminoglycosides, fluoroquinolones such as ciprofloxacin, tetracycline and macrolides, and in some cases, such as the NDM bug that I was talking about previously, to meropenem. So that means it's wiping out all drug classes except for colistin and tigecycline. And tigecycline is very limited range, and colistin will fry your kidneys in about 7 to 14 days. So neither drug are really ideal. So the best analogy of this mobile resistance element, you know, how can it's not just that I'm acquiring a whole lot of E. coli, I only need to acquire 2 or 3 E. coli, and then the genes from that NDM E. coli jump out of the bug and infect my susceptible E. coli to make them superbugs. So the best analogy is a washing machine. And you have all these white T-shirts which you put in the washing machine, then you add one red T-shirt. And then at the end of it, all your T-shirts are red T-shirts. Now the red T-shirt didn't multiply, it just spat out its gene or its pigment and turned all the others into red T-shirts. And so that's probably the best easy to understand analogy. And this is my friend Ken Montgomery, one of my patients, and he best identifies the concern that I have about agricultural use of antibiotics. So Ken is a businessman who came in to have his transrectal prostate biopsy. As for those of you who don't know, what you do is you pass a tube up the rectum, you punch holes through the rectal wall into the prostate, from which you take the biopsies to see if the patient has malignancy of the prostate. So Ken had his routine procedure. Excellent urologist gave him the appropriate antibiotics prior to the procedure, but 36 hours later he presented with multi-resistant gram-negative bacteremia and almost died over the next 24 hours, finally salvaged, but then required 6 weeks of intravenous meropenem to treat his multi-resistant gram-negative intravenously. So he went from having a simple procedure to 6 weeks of having a PICC line and about $200 a day of antibiotics and care. Now, the only risk factor that this man had was that about 6 weeks before his procedure, he'd come back from spending 3 months in France. And you can say, well, we normally think of Europe as a clean, you know, that region as a clean part of the world. But in fact, if you look at their antibiotic use in that region and worse in others, you'll see that in food production, this is a new growth industry. And this is highlighted by Jan Kleitzmann's fabulous paper here in Clinical Infectious Disease, where he actually showed that the E. coli that he found in retail chicken in his country had the same ESBLs in them as what they were identifying in humans who are getting ESBL positive E. coli illness. In fact, his conclusions were, we found significant genetic similarities among the ESBL E. coli isolates from chicken meat and humans according to mobile resistant elements, virulence genes and genomic backbone. Therefore, chicken meat is a likely contributor to the recent emergence of ESBL E. coli in human infections in the study region. Now, subsequently, Andrew Stewardson, who's currently working with me, having just returned from Geneva working with Didier Pitte, did a very interesting study where they cultured chicken meat that was delivered to the kitchens of the University of Geneva Hospital, and in fact found that 92% of all the raw chicken meat was contaminated with ESBL positive gram negatives. Interestingly, hardly any of the cooks who they cultured, who are in the kitchens, had this in their faeces. So what that shows is that actually hand washing and all the very strict infection control procedures that are inherent in food production will protect you. But this is an important public health message which I bet most Australians or most French don't think about when they're cooking their evening meal. And then, of course, Peter here in the audience, along with a couple of other authors, actually estimated the number of additional deaths in Europe per year associated with this problem, and estimated at around 1,500. I don't quite know your maths, Peter, but it'll do. But anyway, it's obvious. I think it's probably more than 1,500, but 67,000 excess length of stay bed days. So you can see this is a big deal. What about other regions? This fabulous paper from PNAS looking at the rates of resistance genes in Chinese swine farms. And this is particularly notable. This is this sort of heat map showing that the massive amount of antibiotics that are now being used to produce. We're now producing pork and chicken and seafood on an industrial scale. So that once you move from pasture-fed or routine food production such as we have in Australia to intensified farming practices, the only way you can get economy of scale is to basically use antibiotics or very strict infection control procedures in those sites, because transmission of infection from one bunch of animals to another is just almost inherent. And so this study looked at the massive use of antibiotics in China, showing that in fact all the downstream effects, so that the animals were fed antibiotics to, in some cases, make them grow faster, but more often to stop them cross-transmitting respiratory infections and so forth, that their faeces then was loaded with E. coli and other gram-negatives that were multi-resistant. That faeces was washed down onto the paddocks. In some cases, those genes were incorporated into the grass and the fodder that was being fed to those animals. And of course, when it rained, that manure was swept into the riverways, and those organisms and those resistant genes were swept downstream, where the water was then drunk by towns further down the stream. So it's led to summary papers like this, and you could say, well, this is just limited to antibiotics, but no, it gets worse. So that now in Europe, to try and extend the trucking range of fruit and vegetables from some countries so that they don't go off in transferring from one region to another, there's been a growth in the use of azole antifungal sprays, particularly drugs that we would normally rely on to cure our chemotherapy and transplantation patients, such as voriconazole. And this fabulous paper looked at the rising rates of resistance to voriconazole amongst Aspergillus species downwind from orchards where they were using these sprays to protect the orchards. And so this is just a map of Netherlands where they looked at this. And it's interesting though, when you look at the data in this editorial that followed this, that they commented from David Denning that the global crop market was worth 48 billion in 2011, is growing at about 5% a year. Of all the pesticides sprayed on crops, 40% are fungicides, and more than 25% of those are azoles. So we're now using fluconazole, voriconazole and posaconazole, and it receives the wastewater from approximately 90 pharmaceutical manufacturers, which empties the water source for millions of Indians downstream. So here's the river downstream, and there's been studies done looking at the toxic effect of this, such that tadpole larvae now grow at growth is inhibited at 1 to 500 dilution of this river system, that the milligrams per litre of many drugs such as Cipro and others are now incredibly high, and some higher than the therapeutic serum concentrations, and that there's about 44 kilos of Cipro in this river per day compared to the 9 kilos of ciprofloxacin used per day in the whole of Sweden. So downstream is about 1 gram of Cipro per kilogram of river sediment, and really if this was gold, people would be down there panning for it, okay, but it's not, it's considered waste. But this has an environmental impact. So this is an interesting TED talk, actually, if you're interested in this topic, by Dr. Larson. So really we're like this. I mean, this is just dumb and getting dumber. It makes you start to feel like this, and then finally like this, and then you turn to drink. So what are the Australian issues and initiatives? And you know, there are some things we can do. So first of all, Australia's been a leader because of this, largely because of this report, the so-called Jeddah report back in 1999 that John Turnage led, and Peter obviously was involved in that, as were many others, which actually predicted what we're going to face now back in 1999. The question was, why didn't anyone listen to it? there have been subsequent publications directly looking at agricultural food use of antibiotics. So in fact, last year there was a Senate inquiry led by Richard Di Natale, who's a member for the Greens, who actually is a GP. It's pretty interesting, is what I'll get to in a minute, and that is amongst the pork producers, there are actually a number of vaccines available which can avoid them using any antibiotics, but they got tangled up in the mad cow disease ban on imported vaccines. They had nothing to do with beef production or coming from BSE, but any imported vaccines of animal use were banned at a time when everyone was worried about mad cow disease, but in fact it was a bit illogical for this. So their argument, we should be re-looking at what vaccines we can bring into the country. So if we come back to this document, does Australia adhere to this? No, the answer is not. We're pretty good, but we're not totally adherent. So if you look at a brief summary, this is just my summary of, chicken. Is there a lot of antibiotic use? Well, actually, it is pretty high. Pork, yes, it's moderate, but it's decreasing, and I'll show you some data. They're very interested in reducing their use. Beef, well, there's hardly any antibiotic use in pasture-fed beef, but in grain-fed beef, almost all the cattle get given antibiotics because they're herded into feeding lots where they get respiratory tract infections. So I personally don't eat grain-fed beef. It's a fad. There's no reason for it. We have fabulous grass-fed beef, and they're never given any antibiotics. Lamb, similarly, is grass-fed, no antibiotics. Dairy, well, it depends. Until just recently, the government has just changed the regulations on one of the macrolides, which previously was being routinely added to the feed of dairy cows. So this will be interesting to see whether there's changes. And when you think of the massive market that dairy now potentially has in countries like China, it is important that we market our product as a clean, green product rather than being contaminated. And then, of course, there's things like crops and seafood, and I've already mentioned that. And then, interestingly, so actually this is the height of my publishing career, where this article was, after I gave a talk at the Dairy Foundation, I was actually quoted in the Weekly Times, which is a farming magazine, which I get every week, and so my kids said, "Go, Dad," It was page 74, actually. But it was on the right-hand page, not the left-hand page, which is always there. And then, of course, there's this new whole initiative in insect farming. So actually the quickest, most cheapest way to produce protein is to grow crickets and locusts and things like this, because in a cubic space they produce more protein than anything else. Heaven knows what we'll think about in terms of antibiotic use for them. So what are the Australian studies? Well, they're largely focused up until now on diarrheal pathogens such as Campylobacter or Salmonella, or looking at directly acquired pathogens rather than resistance genes. And a key focus has always been E. coli. And I think that in some ways this information has been used to misrepresent the situation. And Peter and I know one individual in particular who constantly says there's no information to show that there's multi-resistant genes out in the being produced, or multi-resistant pathogen in Australia. Well, of course, that's the reason, because no one looks and they're not legislated to look and so forth. So it's not that there isn't any, it's just that no one's looking. This is a paper, I think, Peter, just recently, your group looked at E. coli in poultry presented at ASM this year. My concern with these sort of things is that we're only looking at E. coli, and this has been a traditional, it's just been a traditional thing to do. And so these are two of my med students, Jade McClellan and Josh Pitcher, and they teamed up with Mary Barton, who is a vet from South Australia, and this guy, John Burke, who is the president of the Victorian Pork Association, and they're very keen to rid themselves of using any antibiotics. And when you go to his farm, it is spotless. It's stainless steel. The infection control there is better than at my hospital. And the reason is because every week he is producing $200,000 worth of pigs, $200,000 a week, and he cannot afford to lose 1 week's supply. So this means big business, and the two guys went out to his farm and saw how pigs were raised, and then went to the abattoir to see how they were slaughtered, and similarly went to chicken farms and so forth. And although I can't present all the results of this, because in fact it's being presented in 3 weeks' time at the big US infectious disease meeting, what I can tell you is that these are the different supermarkets, and so what they did was they went round and sampled 30 supermarkets and butchers' shops around in the catchment area of the Austin Hospital, and for a certain fee I'll tell you which ones were positive. And then they cultured it on selective media to look for ESBL containing gram negatives, not limiting it to E. coli, looking at it all different gram-negatives. And so this is just for Australian pork. The good news is that there was very low rates of multi-drug resistant gram-negatives in Australian pork. Now, you may not realise, but when you buy pork at the supermarket, if it does not have a bone, it is not Australian. It's all imported. It'll either be from Canada or from Denmark. So all the ham, all the bacon is all imported, not tested. So what they did was they went out to those supermarkets and bought pork spare ribs with the skin on, because it's the skin which is important, and chicken drumsticks which had skin on. It's the same with chicken. If you buy chicken, well, chicken's a bit different because often it's been filleted, but anything that's got bone in it has to be Australian produce. If it doesn't have bone, particularly pork, it's almost always imported. Now, all the Coles and Woolies stuff at the deli, that's all imported, not tested. So what these guys found was that actually there are very low rates of ESBLs, high rates of ESBLs. 97% of all chicken and pork they looked at had ESBL containing bugs on the outside, hardly any E. coli. But that was about it. They were not resistant to all the other antibiotics, which is what we're seeing overseas and what was being reported in the Netherlands and in Switzerland. So these are the similar rates for chicken. So what we see from this is that there's an importance in looking at gram-negatives other than just E. coli, because those other gram-negatives still contain those resistance genes on plasmids and are just as infectious as E. coli, even though E. coli has been the traditional bug to look at. That overall there are low rates, as I've said, in chicken and Australian chicken and pork, that ESBLs were particularly common though, and that some of them displayed antifolate resistance. Trimethoprim sulfur was interesting. The sites where we found that were in the industries where they use Bactrim routinely to stop the pigs from getting chest infections, and that's the very disease that could have been presented by introducing one of these vaccines. What's the source of contamination? Well, that's unclear because we were buying it from the supermarket. And in fact, the commonest strain was actually Acinetobacter. And I think this is, raises a question of actually where the outside of the meat is not getting contaminated back at the farm, but rather at the deli where they're chopping it up and packaging it up. So there's some important public health messages here in terms of both food, such as at the supermarkets, but also if the average person knew that they need to wash their hands and clean the chopping boards and so forth to avoid this, they would do that. So a new approach is needed in Australia. We need to legislate to require foods to be tested for AMR pathogens as well as antibiotic residues so that we can test both local and imports. I think we'll find the imports are worse. We need to reassess the importation of some vaccines. We need to provide a greater focus on infection control in farms, just as we have in hospitals. We need to include AMR and antibiotic use on all farming and food production agendas, a One Health approach. And probably we need to reposition Australian food as high quality and safe with a greater quality focus on quality versus instead of price and quantity where we're value adding. So the leaders in this so far have actually been the Australian pork industry, but we need to get groups like the National Farmers Federation and others who seem to be fixated with low price and high volume to reassess this. So just in conclusion, what we can say is antibiotic resistance is no longer simply a health issue. It's now a social issue, it's an environmental issue, and pretty soon it's going to be a major economic issue. Current situation regarding new antimicrobial developments is a major problem, but it's going to take more than a decade to fix, and in the meantime we need to introduce a fire break, and I've mentioned 5 suggestions of how we could do that. But finally we need new Australian initiatives, a really genuine One Health approach with new legislation requiring setting up a system of surveillance for AMR, and a new priority in terms of avoiding inappropriate antibiotic use in food production. But what we need most of all is action, and if we don't do this, we're probably going to be left like this with this as our last resort for killing bugs. So at that point I'll stop and thank you for your attention.
Well, thanks very much, Lindsay, for a very stimulating talk. We've got about 5 minutes for questions if people would like to ask any questions.
Thank you, that was a great talk. I just had a thought about what you would linking extreme rates of sterility, like a very sterile environment, linking that to emerging rates of allergies and non-Hodgkin lymphoma, which is seen in some European countries. What are your thoughts on that? Having that extremely sterile environment, and then you see emerging rates of allergies and non-Hodgkin lymphoma.
No, it's a good question. So I don't think we're talking about an extremely sterile environment. I mean, the kids are still going to go out. My kids went out and ate dirt like every other kid, and I think, you know, we can be overly obsessed with it, and I guess it's an example, you know, this obsession in the supermarkets of having alcohol-based hand rub now for sale in supermarkets and every mum having it on their hand. I mean, it's probably not necessary. It's more important in places like hospitals where we're putting all the patients together. So I agree with the sort of tenet of your argument that you can go too far, but we're not even close to that. You know, I mean, when you see photographs of prawn fishermen or salmon fishermen pouring buckets of ciprofloxacin into giant pools where they're breeding the fish, you know, this is a different matter, I think.
Thank you.
Should we all be vegetarian?
Well, actually, there have been that sort of argument. The problem is a lot of the crops now are being sprayed with similar chemicals and antibiotics. I mean, bacteria aren't just involved in protein production, so it's also in other productions. So, and there have been a number of studies showing that actually the rates of some of these bugs are about the same if you're vegetarian or not. What is interesting is the rates of contamination of food products is actually higher from organic farms than non-organic farms, because you're actually pouring manure, using manure as the primary fertiliser source, so it depends what that animal was fed before you use their manure. So it's not quite as simple as being a meat hater.
Thanks very much. There are certain situations, obviously, where farmers that have to use antibiotics. So, for example, a large mob of sheep that get infected feet. I think you have to withhold them within 3 months after administering antibiotics. Is that good policy, and is that going to overcome some of the issues where farmers simply have to use antibiotics to salvage the health of their sheep or stock?
No, look, thanks for that. Look, by no means did I suggest that, I mean, sheep are entitled to antibiotics if they're sick the same as humans. I think that what I'm not arguing is that we should withdraw that sort of therapeutic use for animals. That's absolutely mandatory, and indeed the whole production cycle requires it. I think, though, we need a tightening of the use of antibiotics in animals, and that the therapeutic use for animal production is such a tiny proportion of the amount of antibiotic, the tonnage that's used currently. I mean, I actually envisage a day when, in this One Health initiative, you know, farmers actually are very, very similar to doctors. You know, we've been doing some personality profiling on medical staff, and, you know, doctors are highly individualistic. They're used to working on their own and problem solving on their own. They dislike, you know, authority and being told what to do, and they'll always listen to their neighbour or their colleague more than they will 1,000 randomised trials. Well, this sounds like a farmer, right? And so actually there's, you know, and they sort of usually solve the issue themselves and have strong opinions and tell everyone else what to do. So, you know, I can see actually a growing alliance, at least for Australian agriculture, between the farming sector and the green sector. You know, they will become more environmentalists than the strongest environmentalists, really, because their future and their livelihood depends on it, and there is no future in misusing antibiotics, because that makes Australian agriculture just the same as the whole of Asia, and we will never be more successful in Southeast Asia because of the production. So therapeutic use of antibiotics for animal production is absolutely critical. The issue is making it similar to what's happening with humans, and that is only by prescription and by the qualified personnel.
I think we have one more question there, and then I'll take those last questions.
I was wondering what you thought, bearing in mind that a lot of this overuse or misuse of antibiotics is economically driven, whether taxing antibiotics for use in agriculture, and perhaps obviously it needs to be more complex than that, but maybe we need to start doing that the same way we do other undesirable materials.
Yes, I think the idea has been proposed before, not just for agriculture, but for human use too. So, you know, I don't know if you realise, but, well, at least in my hospital now, ceftriaxone is 70 cents a day and benzoyl penicillin is $15. So when we recommend using penicillin G instead of ceftriaxone per day, it's costing the hospital, you know, ceftriaxone is now so ridiculously cheap that it's encouraging misuse. If you are only going on economics, you would just use ceftriaxone and meropenem, because meropenem is now $7 a day instead of 75 like it used to be. So all the generics which are being produced from India are now so cheap that one could legitimately argue that actually a tax should be applied on them to discourage inappropriate use, and with that, and the same would apply with the antibiotics that are commonly used in agriculture. I think a key thing is removing antibiotics from feed, so it's just not automatically added, and at least for this recent S4 switch for one of the macrolides, you know, when the vets actually looked at the concentration that was being added to feed, it was about 1/10 of the therapeutic concentration needed to treat an animal if you were using that macrolide for therapeutic purposes. So it's the perfect way to encourage emergence of resistance. And so, you know, there's some structural legislative things that we could do, but I think your idea of somehow readjusting things, whether it's a tax or not, is reasonable. Yeah.
Okay, well, thank you very much. We have one last thing to do, which is to give you a present.